So if we look at the slide on the left A, these are 4 of aortic M mode, and aortic M mode is a fair game for exams because it can manifest so many of interesting findings, and they want you to know exactly what each morphology and depiction of M mode in aorta means. The one on the left, the A, what do you think it means? The closure line is a bit what? Is a bit eccentric, okay? It can be more eccentric than this one, but this is a bit eccentric, and this is a glimpse to a bicuspid aortic valve. Yeah, yes, exactly. Okay. Now, look at this one here, B. What do you see? What do you see here? It is mid-systolic
closure.
Exactly.
Mid-systolic indicate hookah.
Exactly. This is mid-systolic closure indicating hookah. Good. The one on the C.
Where is C?
Any guess? See how it does.
Aortic regurg?
Not really. What you see in here, if I can schematize it for you, it does look like this. So something going up. Sorry, I wanna try to. It goes like this and then like this. So instead of going this way, something goes up, then it closes early, then it opens again. So if you compare the 1C with the 1B, B is mid-systolic. This one is early systolic. So what does that mean? Early systolic closure of the aortic valve.
Subaortic membrane.
Thank you. Exactly.
Subaortic membrane, yeah.
It is, yeah, subaortic membrane. So see, this aorta, by the way, it can closes in the mid-systole by a notch, and this is hookah. It can show a notch early in systole, and this is subaortic membrane. Okay? Now, if we see the last one, the D, what do you think about it? What is it here, D? This one. See the ECG at the bottom. The ECG at the bottom. There are obviously some BVCs, and this is a premature, and this is after the pause. So what happened here, if you compare this beat to this beat, you see that the aortic valve here opens prematurely. If you compare it with this one, you see this premature, the arrow pointing to the premature opening of the aortic valve. And that comes after the pause. So premature opening of the aortic valve after a pause, does it mean anything? Yes, it does. It means, again, a diastolic dysfunction and high LVEDP, because the valve start to open in diastole. It start to open in diastole because the pressure, the diastolic pressure, is really high, and exceeding the aortic pressure, and it start to split the valve open a little bit. So that means the pre-existing diastolic pressure is high, and upon that we have an increased filling because of the pause. So these two factors come together to open the valve prematurely. But usually when the aortic valve opens prematurely, it means I have a pre-existing diastolic dysfunction. Okay, like in this case. Okay. So far so good? Uh-huh.
Yeah.
Okay.
It's okay.
Right. Now look at this
معلش يا
here.
دكتور
This,
حاتم أنا دي ما فهمتها.
okay.
دكتور حاتم
Yes.
معلش أنا
Yes.
آسفة الفاتت دي أنا ما فهمتها. يا تا فيها في النص دي PVC صح؟
في النص PVC, yes. And
The
if
one
you
in
check this
the
one
middle.
here, this is the
طيب.
PVC. This is after the PVC, after the pause. If you compare here, you see the opening here. It's sharp and it's right. It opens in systole, no problem. But this one is start to open in diastole. Okay.
Okay.
It start to open in diastole because of the high LVEDP. Added to that, the high diastolic filling because of the compensatory pause. Okay, you get it now, Hanin?
Okay.
Okay,
Yeah, I did. Thank you.
okay. So let's move on here. And this one is a signal that it obtains from the liver. So what is it or what does it mean? This one, I mean the one on the left, not the one on the right. The one on the left from the liver, the one on the right from the tricuspid valve. Okay, so the one on the left, what does it mean?
Diastolic flow reversal.
Exactly. So this is an interrogation of the hepatic vein. So it's a hepatic venous Doppler, and it shows a diastolic reversal. So this one here is a diastolic reversal, this one. Diastolic reversal, diastolic reversal. What does that diastolic reversal mean?
when it yes when it doesn't relate to respiratory cycle, usually it goes with severe pulmonary hypertension.
Again?
يعني when I didn't find it relating to the respiratory cycle, that is to say augmentation in inspiration or expiration, usually it goes with severe pulmonary hypertension.
لا diastolic
reversal can occur in
يعني
multiple
إلى حد
carditis.
ما sorry
Diastolic reversal.
A very severe TR can lead to
لا systolic reversal. systolic reversal. Systolic.
And what do you think
Diastolic
about this
reversal
one?
بتحصل في 3 conditions.
لا, what is this one? Is it systolic or diastolic reversal? The one I'm pointing to.
This is systolic يا أبو صح؟
Huh?
This is systolic.
This is systolic, yeah. This is systolic reversal, you see?
Yes.
Sorry,
Yes.
I don't know what's happening here, but it's timed with the, yeah,
Systolic.
With
systolic. Yes, this is
severe
systolic
TR.
reversal.
Yes.
This is severe TR, okay? And we can say that confidently, it is severe TR, because usually we have to have a down flow below the baseline because it's forward flow. That's why it's depicted below the baseline. But if it flips above the baseline, means it's reversal. It's not going forward anymore. It's coming back because of the severe TR, okay? So when the TR is large and severe enough to go all the way into the liver, to spill over into the liver, it must be severe. That's why in clinical exam, when we palpate the liver and we elicit that pulsatile liver, we are happy to diagnose severe TR. So pulsatile liver is a clinical equivalence of
Prominent
this systolic reversal. Yeah, this systolic reversal, exactly. Okay? So the systolic reversal and the pulsatile liver are the same thing. Okay. Now the one on the right is the TR signal. And again, the way it looks suggests severe. Tell me how.
Yes. Early peaking. Early peaking.
Okay. Can you elaborate
Triangular
further?
in shape.
Okay, great. So that
الويت
yes, all right.
الويت برضه بتاع الشيب.
Yes. So if you see here, usually what we see the TR, they look like rounded signals. But now when it tends to take that morphology like this one, Disugi said it's triangular, I guess, yes? That means severe, yeah, because that indicates a high RA pressure. So the contour of the signal is so meaningful, If I see MR or TR that depicts this triangular contour, I'll be inclined to diagnose severe. Now, if I look at the density is also meaningful in terms of severity, but I have to be cautious because the density is not only about severity, but it can be about, are you striking the right alignment? Where are you hitting and stuff like that? And again, setting and all of that. Now, other thing is the velocity here. What about the velocity here? Does it have anything to do with severity? I mean, the peak velocity of the TR. Does it have anything to do with severity? The answer is yes, no, or you don't know.
No.
نو لأنه لو كان تورنشيال الفالف فاتح ما بيفتح ولا بيفتح ولا يعني ثابت حتته وفي جاب you cannot يعني بيحصل under estimation
Or
Yes,
pulmonary hypertension.
Very good, very good. So this is a problem I meet a lot with our technician when they do the echo and they see a torrential TR, and when they interrogate it, the big velocity is not high, and they come back to me like, how come? It is so rational. The more severe the TR, it tends to decrease the peak velocity of the TR. You know why? Because the more, this peak velocity is what? It's the outcome of what? It's the RV, RA pressure gradient. RV, RA pressure gradient, right? So if this pressure gradient increases, velocity increases. If this pressure gradient decreases, velocity decreases. Now let's see when we have severe TR, what do we have? The severe TR decreases the RV pressure because it tends to weaken the RV. So the RV systolic pressure tends to be weak. Conversely, the RA pressure tends to go high. So the gradient tends to go low. So the velocity tends to go low. So there is no correlation between the velocity and severity. And in fact, if there is a correlation, it's an inverse sort of correlation. Meaning, the more of severe MR you have, the more likely to have lower peak velocity of the TR jet. Okay? You get this point? Okay.
Yes. So Dr. Hatim here, when we are assessing the PA pressure or the pulmonary pressure in conditions in which we have severe TR with low signal.
Okay. You are so likely to underestimate the pulmonary artery systolic pressures. And that's why when I have severe TR, I shy away from reporting pulmonary artery systolic pressure. Or at least I will write maybe underestimated. Okay, for the same reasons we have discussed.
Okay. Thank you. Can
Now,
we go invisibly?
We can use the pulmonary regard or pulmonary to assess.
Yes, exactly. In this case, we have to resort a recourse to pulmonary outflow, the PR signal and all of that. And I'm going to show you some of them in a bit. Now, see the difference. This is MR. Again, I'm going to stress on the point of the contour. Look at the mild MR here, the mild MR and the severe MR. So the contour is different, right? It tends to be triangular in the severe MR. Now, when you look at the pulmonary venous Doppler, look here. What do you see? Pulmonary venous Doppler. The pulmonary venous Doppler is usually S,
Systolic reversal.
D, and AR. So it looks like that. S, D, and AR. S is systolic,
Yes, it's
ventricular systolic.
the
So if I have severe MR, so instead of the flow in systole going toward the ventricle, it's going back into the left atrium. That's why I get the reversal. And here is the reversal, the S.
yes.
The S is now
Systolic
down.
reversal.
Exactly. So the systolic reversal of the pulmonary venous Doppler indicates severe mitral regurgitation. Okay. And remember in Dr. Muktaba's lecture, we said that this is a specific sign with a high degree of positive predictive value. But you have to be cautious. If you don't demonstrate it, that does not rule out severe MR, because it's not the function of severe MR alone. The architecture or the geometry of the left atrium and the geometry of the jet have a lot to do with this reversal. Yani if the jet is kind of eccentric and wall hugging, it might not reach into the pulmonary vein. If the LA is big enough to digest the jet, it might not go backward. So it's a function of the LA geometry, the jet geometry, and the severity. So you have to be cautious. If you see it confidently, that's severe. But if you don't demonstrate it, you can't rule out severe. Okay? Good. So
Dr. Hatim, هنا السيستوليك wave in moderate maybe blunted مش كده؟
Yes, exactly. Exactly. طبعا it's not all or none. It's not just upright and reversal. There are some degrees in between. So when you have moderate, moderately severe, you start to have blunting of the S until it flips down the baseline. Okay, so I agree with you in this.
دكتور
Okay,
حاتم
and this
احسن بالمونوري يعني هو اكتر في البوستيريال ولا في البulmonary vein we can see a jet more?
Usually we are interrogating the right upper. In
Right
TE,
upper.
of course, yes, the right upper. That's what we do in transthoracic echo. But in TE, we can interrogate the four of them, okay? But in transthoracic echo, you just have one chance, only the right upper. That's the one you can interrogate. And you can have a crisp signal for analysis in only 70% of the cases. So in 30%, you cannot have a good signal for interpretation or analyzable signal, okay? But in TE, things are different. I can see the four and I can interrogate the four and all of that, okay?
Okay.
How about in diastolic dysfunction, Dr. Hatim?
Yes, in diastolic dysfunction, yes, I'm going to show you now how it looks like. This is the TR. Again, the TR, I want you to focus on the signal morphology of the TR. It's triangular in severe. And when you see the hepatic venous flow, the S and D are both below the baseline. Now the S is up the baseline in severe TR. That is the systolic reversal of severe TR we have discussed. Okay. Now when we come to the AR, we have the AR deceleration time. You see the one in the middle, the AR deceleration time, and the reversal in the descending aorta. Okay, the reversal in descending aorta. Good. Now, what about the deceleration time and how that correlates or associate or means severity?
Less than 200 indicates severe AR.
Okay.
More
Good.
than 500 indicate mild, in between moderate.
Good. Okay, so this is a good rule of thumb. Look here, you see, this is the deceleration. Of course, that's longer time. When you compare this one with this is shorter time. So the steeper the deceleration curve, the more likely the AR is severe. With a pinch of salt, because again, the deceleration time of the AR is not the function of severity alone, but it's the function of severity and the pre-existing or the coexisting LV systolic function. LV systolic function, okay? That's why if I have a severe AR, torrential AR, but the ventricle is well compensated, I might not demonstrate that. While if I see moderate AR acutely developing in unaccustomed LV, it might lead to short deceleration time, okay? So take it with a pinch of salt. Now the reversal in the descending aorta, it is so meaningful. And if I demonstrate that much of reversal in the descending aorta, I'm confident towards diagnosing severity, okay? So by now, I know that the TR, if severe, can lead to systolic reversal in the hepatic venous Doppler. The MR, if severe, it can lead to systolic reversal in the pulmonary venous Doppler. The AR, if severe, it can lead to diastolic reversal in the descending aorta. Agree? Good.
Yes.
Good. So, now, what do you think about this one here? I have the one on the left, it showed some abnormal excursion of the septum in the MO. That's the septum. The one on the right is a dilated plethoric IVC with dilated hepatic vein. C shows a high EA ratio is more than 3. D shows the medial E prime velocity is like 19. It's a lot. So what do you think about this?
Pericardial
These
constriction.
together are suggestive. Exactly. This is constriction. Why did you say that? Why did you say that?
Number one, we have dilated inferior vena cava with loss of respiration. And we have systolic bouncing of the interventricular septum. And we have advanced diastolic physiology, advanced diastolic dysfunction. And the medium E prime is normal or exaggerated. So the medium velocity is not involved. Rather, in contradistinction to the lateral, which is restricted by the constricting pericardium.
Annulus reversus.
Annulus reversus.
Yeah,
Exactly.
No.
Exactly. So this is so important when you have this, the medial E prime, because it's free. When you have constriction, I mean, a tough pericardium shielding the heart from outside. So the medial E prime is hyperdynamic. It tends to be hyperdynamic. So this is one thing. The other thing is the lateral E prime is constricted by the pericardium. So now we have a situation which is contradicting the physiological situation. In the physiological situation, the lateral E prime is faster than the medial E prime. So when we get the reverse, that is suggestive of constriction, specific sign of constriction, okay? Now, a question here, which pulmonary blood pressure is higher? In the one on the left or on the one on the right, and why? This is, I think, Hanin or who talked about when we are having severe TR, we don't know exactly the pulmonary artery systolic pressure. We are not sure about the accuracy because of severe TR about the pulmonary artery systolic pressure. So we might seek some other measures, one of which is this PR signal. So this PR signal, now, which one suggests severe or more severe pulmonary artery systolic pressure? The one on the left or the one on the right?
The one on the left has PR.
I see the left.
On the left indicates
On the
severe.
left.
The one on the left more severe than the one on the right.
The one in which there is systolic notching is has severe pulmonary artery pressure.
Okay.
Severe AR.
Okay.
The one in which
So,
there is a notch.
A notching. Okay. So the
Systolic
one with notch, you
yes,
think it's more severe.
Yes.
This one is more severe than this one. Type. Okay. Look at this one here. The pressure. These are diastolic pressure. They are higher than in here. Does that mean anything in terms of which diastolic pressure is higher?
Yes. The second one. The
Exactly.
right one.
So first and foremost, the higher the signal is, the more diastolic pulmonary pressure. So the more pulmonary hypertension. So the one on the right tends to be of more diastolic pressures. So I'm expecting more of pulmonary hypertension on the right, and we are right. Other thing, actually, this atrial dip or notch, when it's there, it votes against severe pulmonary hypertension. And when it disappears, it is severe pulmonary hypertension. Now, why is that? You see, this PR is a function of what? It's a function of pulmonary diastolic pressure minus what? RV diastolic. You agree with that, right?
Yes.
So, yeah, okay. I don't know. So it is this gradient that's the one which propel this PR. It's the pulmonary diastolic pressure minus the RV diastolic pressure. Good. Now, what is the atrial dip here? The one we see on the left. The atrial dip is what? The atrial dip is when the atrium contracts, the right atrium contracts, it elevates the RV diastolic pressure. It elevates the RV diastolic pressure a little bit. And when it is elevated a little bit, the gradient decreases and the flow tends to decrease momentarily during this particular time. That's why we have this atrial dip. Now compare this to a situation when I have a pulmonary diastolic pressure that is way high. Whatever happened in the RV diastolic pressure, this momentarily increase with the atrial contraction is not going to affect the gradient. The gradient is still high because the diastolic pressure of the pulmonary artery is overwhelmingly high. So I don't see any atrial dip, okay? So the absence of atrial dip suggests severe, and the diastolic pressure, which are high, suggests severe, okay? You get it? Good. Okay, now this one is the reversal in the descending aorta of aortic regurgitation. Compare the one on the left to the one on the right. It's easy to tell which one is severe. The one on the left, severe. The one on the right is not severe. Now, do you have any quantitation to this reversal that can help you to tell is it mild, moderate, or severe?
Yes. Yes.
What is that?
LV in there. So
We
LV
can measure
LV is the pressure.
We can measure what?
LV in there.
We can measure the end of the wave. We can measure the end of the wave. If it's more than 20, the elevation is more than 20, indicate.
You mean this one?
Okay,
we measure this one. Okay, we measure this one. We measure the TVI, time velocity integral. So it's more than 20. Yes, that is severe. Why we should go quantitatively is because, you know what? You can have reversal in normal or you can't. Can you? Yes or no? Can you have diastolic flow reversal in the descending aorta in normal subjects? The answer is yes. 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 There is a physiological flow reversal. Now you can also have it with mild. You can have it with moderate. You can have it with severe. So it's not a matter of whether or not there is reversal. It's a matter of how much. That's why let's go quantitatively. We quantify how much we have. TVI more than 20 is meaningful. Okay, good. Now, this one is a patient of mine, and this is the descending aorta, and you see the reversal. It's big deal, right? So without quantification, yeah, but I think if we apply TVI, it will be more than 20. This is the descending aorta. Now, what about this one here? This is abdominal aorta.
Yes.
And what I am seeing noted by the arrows is what? Is diastolic
Or diastolic reversal.
Exactly. So if I demonstrate the reversal into the abdominal aorta, this is severe, probably without quantification.
Yes.
Without quantification.
Yes.
Because of the AR comes back from the descending aorta, it must be severe. That's the idea. So in the abdominal aorta, probably we don't have to go quantitatively. But in the descending aorta, we have to. Okay? Now, what is this here? These are signals for the same patients. One is from, consequently, mitral valve, the one on the left, upper left, LVOT, tricuspid valve, and the IVC. What do you think is going on here? What is going on here?
Pericardial constriction.
Oh, طيب. Constriction. Why? Why constriction?
Few respiratory
variation.
Variation in the tricuspid valve and in mitral valve.
Okay.
Yeah.
Okay. Good. And a pyloric IVC, right?
Yeah, IVC
but will constriction explain this one? This one? The LVOT? Will explain it?
Could be cardiac tamponades.
Oh, great.
Yeah.
Okay. Who is speaking? The Sugi?
Ahmed Noor.
Ahmed. Yes, yeah, Ahmed. Yes, yeah. Exactly. I might agree with all of you. If the LVOT signal was not there, it can be constriction, can be tamponade. Okay? But if I have LVOT showing these swings, these changes, no. That is different. Constriction does not cause that. Now, Ahmed, can you tell me what's going on in this LVOT tracing? What's going on here?
In case of cardiac tamponade, will be decrease.
Yes, decrease.
LVO2 velocity. With expiration.
Decrease in the LVOT velocity in expiration. Okay, in inspiration. Yeah.
Diastolic collapse of the RV.
So you look here now.
Also
what
decrease in mitral Doppler flow velocity by more than 40% during.
Exactly. So yeah, I wanted to show you something here. Look at this one, the LVOT. What am I seeing here? Sorry. See? Sorry, goes down. So you see, it is what? It's not beat to beat. It is what? Respirophasic.
Yeah,
respirophasic. Changes are respirophasic. So it decreases at some respiratory phase and increases in another. During the time when it's low, that's the inspiratory phase. So the LVOT pressure decreases during inspiration, and that is a tamponade physiology. And the clinical sign which is equivalent to this one is what?
Pulsus paradoxus.
Exactly. Exactly. Okay. So we can see echo equivalent of pulsus paradoxus when we demonstrate these respirophasic changes in the LVOT pressure, like this one. Okay. Okay. Now, this is the pulmonary venous Doppler. And the pulmonary venous Doppler is so important. I don't know, somehow it attracts the interest and attention of echocardiographists and cardiologists in general. What we see here is the S, D, and AR, right? S, D, AR. You see that, right? S, D, and AR. But now I have two S's, S1 and S2. Have you ever seen that? S1, S2, D, and AR? Yeah. We can see that exceptionally. Usually the S1 and S2 are fused, but sometimes are not. So I want you to be familiar with both morphologies, when they are fused and when they are not. It's more common to be fused than not, okay? But don't be alarmed when you see them like that. Now, what does it mean? It tells us a lot about the physiology. Now, S1, S2, D, and AR. طبعا Dr. Muktaba, last presentation, you have discussed together what each one means. Just for S1 and S2. These are forward flow, right?
Yes, S1 is early systolic flow and S2 is the late systolic flow.
Yes, early systolic flow and late systolic flow. Now, why do I have early systolic flow? That's because of atrial relaxation. So S1 is atrial relaxation. What is the ventricle doing during this time? The LV is what? Contracting. Yes, the LV is contracting, the atrium is relaxing. So S1 is the atrial relaxation. Now we know that during mid-systole, which is the peak of systole, the mitral annulus is a little pulled downward. It's pulled apically. And that will expand the left atrium, decrease the pressure in the left atrium, increase the flow into the left atrium. That's why we have S2. So S2, sometimes they call it the descent of the mitral valve annulus. Okay? Now the D is now the mitral valve opens and I have the first gush of flow in the early diastole. It goes down. Now the AR is what? AR is the atrial kick or the atrial contraction. And when I have atrial contraction, now what I do have is some blood sneaks backward, some of which goes forward, but some of which goes backward. Now the amount of the blood that goes backward depends on the resistance downward. So the more of resistance in the LV to the flow from the mitral, the more of blood goes backward. That's why the AR is so important sign of diastolic dysfunction. So if it gets broader and deeper, that means something. That means the LV is stiff. So from all the hepatic, the pulmonary venous Doppler, the most important one for diastolic function analysis is the AR in terms of duration and velocity. So the more broad it is and the more deep it is, meaning more of blood going backward, meaning more of stiffness is downward, معناتها more diastolic dysfunction. Okay? You get that?
Yes.
Okay. Good. Good. Very good. طيب. Again, this is S1, S2, and the AR, and we quantify the AR in terms of duration and in terms of velocity. And sometime you probably read in the books, they say AR minus A duration. What is this? Now they are encompassing two parameters together, okay? And of course in echo, the more incorporative and the more integrative you are, the more likely to be true. So if you rely on a single parameter, not good. So the AR minus A duration is more magnificent than AR duration alone. Why is that? Because I know that the more of diastolic dysfunction I have, the A duration will increase or decrease if I go to the mitral inflow. If I have
reduced.
Reduced, exactly, reduced. So it gets low, it gets low. It gets like that. So you have E and you have
مشينا هنا ما كان عندها فايل معه.
محمد عبد
الحميد عبد الحميد
محمد
جاء كال لا انا جاء كال ذيك الرش يا بوس هو ولد انا اداني بالتليفون قال لي يا اخي انا بفتكر انها جنبلتها بوس
يا ادمن
ايوه خلاص okay. So E and A in the mitral inflow, what does they both mean? See the A, when you have grade 3 and 4 diastolic dysfunction, what happens to the A? It becomes smaller. Exactly. Hardly appreciable. It's diminutive wave. So it becomes low and slim. Now, when I have diastolic dysfunction, what do I get in the pulmonary venous Doppler? I get more of AR. So more of AR and less of A. So if the AR minus A is more than 30, that means advanced grade of diastolic dysfunction. Okay? So this is a great equation we sometimes use.
AR less than?
If AR minus A duration more than 30, when we are talking about milliseconds, okay?
Yeah.
Yes, that is significant. It indicates elevated LVEDP, and the more of this duration, the more of LVEDP. Okay? This is when you are integrative. Now you are incorporating two signals together. The AR from the pulmonary venous Doppler on one side, and the A of the mitral inflow from the other side. Good? Okay. Now, what do we have here? That's a TEE, and this is the left pulmonary vein, and the one on the right is the tracing, okay? The PW tracing of the pulmonary vein, or the CW tracing of the pulmonary vein. They look so awkward now. This is not the way we are accustomed to seeing. We are accustomed to seeing it this way, you see? Flattish a little bit, but now we have very high velocities. We have high velocities in the pulmonary vein. What does that mean?
Yes, we have augmented the diastolic flow in the pulmonary vein. It may go with a severe diastolic dysfunction.
A severe diastolic dysfunction, like what we have discussed, we usually have AR. We have AR. So the AR tends to be large and big. The AR is down here. Okay, this one. Yes. So these high velocities are so high. Usually it looks like this. Now see how much they are? Big difference. So these high velocities are the result of stenosis. Okay, pulmonary venous stenosis. And the reason is, the most common reason is?
AF ablation.
Exactly.
BVI.
Exactly. Yes, AF ablation. Okay. So great. Okay. So what do we see here? Now we have two M mode signal on top, and a CW signal at the bottom. For a same condition, 3 signals means 1 diagnosis. That diagnosis is
Arcuation of the aorta?
not really.
No. Hookam. Dagger shape.
What exactly? Why hookam?
دقر شيب وفي سام. اول شيء السي دبليو دقر شيب والفي سام.
So this one here is dagger shape. Is dagger shape. Okay.
Yes.
Okay. طيب. And what about this one here?
Here mid-systolic closure.
Exactly. Mid-systolic closure. And what is here?
Sam.
Exactly.
Stump.
And what else? What else? You see the septum?
Hypertrophy. Hypertrophy.
Exactly. Yes. Good. You are so good, actually. Good. This is a bit tough. That's why we're just gonna for it. Now, see here, sometimes, not always, you can demonstrate this one here. Okay. This is mitral. This is the, sorry. This part is what? This is the aortic outflow. And it looks dagger, right? You agree? Good. Now what is this? This is the ENA of the mitral. I have no problem with these two. But usually we don't see this one here. This is so unusual. It's so unusual to have this flow between the aortic flow signal, systolic signal, and the mitral diastolic signal. Usually this period is occupied by the isovolumic relaxation time during which there is no flow, right? It's just a time, an inert flow. Now I have robust flow during this time. What does that mean? That means severe hookam. Okay?
Yes.
Why? Yeah. Because in hookam, especially when you have the mid cavitary hookam, okay? During the relaxation, you have gradient in the LV. So the apex relaxes faster and easier than the base. So the pressure up is higher than the pressure down. So the flow goes from the base of the LV to the apex of the LV. Because of that gradient. Usually you don't have that. Okay, so it means mid-cavitary obstruction and it means severe mid-cavitary obstruction when you have isovolumic relaxation flow that much. Okay, good. Now, again, this is a hepatic venous Doppler. And now I need somebody immediately to tell me what's going on here because we have gone through this one. So what are we seeing here?
Systolic reversal.
Exactly. This is the systolic reverse. Exactly. So what is that? Severe TR. Exactly. Yes. And now, this is a mitral M mode, left and the right. Both patients have one problem, similarly, but in different degree. What do you think about the M mode on the left and compare it to the M mode on the right?
M mode of the left indicates there is early diastolic closure of the aortic valve.
On the left, yeah, huh? And what about on the right?
Aortic regurgitation.
On the right,
The right, I think there is high left ventricular end-diastolic pressure and looks like LV dilatation. Also is fluttering of the
exactly. Yes. Thank you, Ahmed. Thank you. So actually, in both patients, we have AR. Okay, and in both patients, if you focus enough, you will see there is fluttering of the anterior leaflet. The difference between the one on the left and the one on the right is that the one on the right has flutter, and premature closure. Not like the one on the left. Okay? So if you have an AR that impinges on the anterior leaflet, it leads to this flutter, but not necessarily closure. It leads to closure if it's severe. So the closure means severity, the flutter does not mean severity. Okay? So if you demonstrate a flutter along with closure, premature closure, that is severe AR. Flutter alone, not necessary. Okay? Good. Now what do we see here? Again, this is mitral M mode. And we see what? Easy. Prolapses, right? These are all examples of mitral prolapse, and you can see them here by M mode. M mode has a great temporal resolution. That's why we see the prolapse so well like this one here. And we can tell even how long this prolapse occupies in the systolic period. Is it early, late, or mid, or hollow systolic prolapse by this one? Okay. So the M mode is important because of the high temporal resolution. Now there is a problem when we are quantifying the MR of prolapse. One of the most difficult MR quantification is the one that belongs to prolapse. Okay, I spend more time with these patients than the rest of like degenerative MR and stuff like that. You know why? You know why?
Yes.
Mm-hmm. Why the quantification is problematic?
Because it's most likely late systolic jet.
Yes, yes, exactly. Because it's not.
ممكن يكون extentate.
Exactly. This is
والجد
one
برضه
thing.
ممكن يكون extentate في البولابس.
Yes, very nice. So the eccentricity of the jet gets us into the Quanda effect, which might underestimate the severity. This is one thing. The other thing is that it's not hollow systolic.
Yes,
it is mid and late. So what am I gonna use usually for quantification of MR is the venocontractor. How I get the venocontractor? I freeze the jet and I check the venocontractor, the widest neck. That's it. But does that represent the entire systolic period? No, I have chosen a frame, only one frame, assuming that during this time, the MR is always like this. But in the prolapse, that's not the story. In degenerative MR, a single frame is representative of the entire systolic period. So the MR is always like this. But in prolapse, no. The early systole, there was no MR. The mid and late just started. So you are overestimating the MR if you use the venocontractor. That's why you better go volumetrically. You assess it by volume.
The volume, yes.
Okay, yes. Okay, remember that. Okay, now you remember somebody talked about initially about the mid-systolic flow. And what does that mean? This is the mid-systolic flow. You see the E and A, and in between there is L. They call it L hump. Yes, the L hump. So this L hump, and I think one of you has actually said it right, it might be normal, okay? But it might also mean significant diastolic dysfunction, okay? Significant diastolic dysfunction. And you see the B pump, we have talked about the P pump and what does it mean in terms of diastolic dysfunction. And the diastolic MR, and what does it mean in diastolic dysfunction, okay? So now we have the L hump, the B pump, and the diastolic MR, all of which can be due to severe diastolic dysfunction. يبقى لاحظتوا حاجة في حاجة واحدة that bring all these things together. إنه الميترال valve is strongly kept open when it should not. يعني بين ال E and A the valve closes. So during this time we don't have flow. Now because of diastolic dysfunction the valve opens forcibly and we have a flow. The B pump is that the valve tends to close. Now it's open a little bit by the B pump. The diastolic MR, the valve is opens and blood flows backward from the ventricle into the left atrium. Okay, so somehow the diastolic dysfunction keeps the annulus splinted or keeps the mitral valve opens for longer duration than it should. And these all are a specific sign of diastolic dysfunction and of high-grade diastolic dysfunction. Right. Now, what are the magnificent four they are talking about in the new guidelines about diastolic dysfunction? They are talking about 4 parameters. One is the E and A of the mitral, the E prime, the LA volume index, and the TR velocity, meaning pulmonary artery systolic pressure. Good? These are the magnificent 4 of the diastolic function analysis. In echo, the status quo of diastolic analysis uses these 4. Okay? And you see in the new guidelines, they have incorporated the ejection fraction. So the analysis with low ejection fraction takes different track than when you have normal ejection fraction. Okay? So again, the ejection fraction has a lot to do with how you are analyzing diastolic function. And I think we have talked about that in the first session. But I want you to remember the 4 or the magnificent 4 of diastolic analysis. Now, what is this here? If you take these 2, the mitral inflow and the E prime, the E prime is 4. And here you have E and A more than 3, and when you see E over E prime is 22. What does that mean?
Grade 3 diastolic dysfunction?
Yeah, exactly. Could it be grade 4?
Yes.
Yeah.
This depends on the reversibility.
And how can you apply reversibility here?
By Valsalva maneuver.
Yeah, exactly. So usually we say this is a restrictive pattern. It's either 3 or 4, and we just put them together. 3 or 4, whether reversible or reversible, because Valsalva is not so trustworthy. First, patients are not doing it right and stuff like that. And if it's not reversible with Valsalva, that does not rule out reversibility, because reversibility is basically medication-based. Meaning what? If you have this grade of restrictive physiology, and then you treat the patient with beta blocker and diuretics and all of that, and then you repeat the echo and you see how the diastolic function is now. If it changes, that is reversible from the baseline. So the final verdict about reversibility is not the Valsalva, it's the medication, it's the treatment, okay? That's why I myself don't ask for Valsalva in this patient. I will just report it as grade 3/4 diastolic dysfunction, okay? Now look at this one here. The one on the right is a restrictive pattern. And you see the A wave. Do you see the A wave? It becomes so small. The higher the grade of diastolic dysfunction, the smaller the A wave. And the EA ratio becomes high. Now look at the one on the right, on the left. It is the pulmonary venous.
Pulmonary.
Yes. What do we see here? Look at the AR. The AR. Stout AR, stout. It's broad and deep. So if I take the AR duration and I minus it from the A duration from the mitral inflow, I will get something more than 30. Okay? The other thing about diastolic dysfunction in the pulmonary venous Doppler, the more of diastolic dysfunction you have, take this one, the lesser of S, the more of D, and the more of AR. Again, the more diastolic dysfunction you have, the lesser of S, the more of D, the more of AR. You agree?
Yes.
Yeah. Yes, because if you have diastolic dysfunction, the S will get blunted. Why blunted? Because the atrial relaxation will be impaired. Why do I have stout S? I have stout S because the pressure in the LA is so high. So immediately when the valve opens, gush of flow goes down. So that is S, D, that is D. So that's why I have high D. D correspond to the E in the mitral inflow, okay? And now the AR, I have high AR because much of flow goes backward instead of forward, okay? So the more of diastolic dysfunction I have, the less of D, the less of S, the more of D, and the more of AR, okay? Now, when it comes to HFpEF, it's an important entity. And there are 3 obligatory conditions that should be met simultaneously for the diagnosis of HFpEF. You have to have symptoms and signs of heart failure. So you have to have a clinical background of heart failure, or else we should not go into diagnosing HFpEF. HFpEF means clinical. We start by clinical. The other thing is that our ejection fraction when we do echo has to be more than 50. And then we have to have an evidence of diastolic dysfunction by echo or otherwise. If I don't have an evidence of diastolic dysfunction, and the question to all of you, if I don't have a diastolic dysfunction by echo, will that rule out HFpEF?
No.
No, yes.
Explain. Why?
It's not ruled out because diastolic dysfunction is the one factor that lead to heart failure with preserved ejection fraction. It is multifactorial. One factor of them is diastolic dysfunction. So the diastolic dysfunction can prove there is heart failure with preserved, but it's not exclude at all.
With structural heart disease, we can get enlarged LA or LVH plus high BNP.
Good.
Yes.
Good. Okay, here, by the way, when we say HFpEF, I won't be confident to diagnose HFpEF unless I clinch on a diastolic dysfunction. Somehow, either during echo basal condition, patient comes and I do and I find it. If I don't find it, I will try my best to unmask it. How can I unmask it? By exercise. So now, starting from 2016, the new guidelines includes the so-called diastolic reverse assessment, which is diastolic stress testing. Okay? Diastolic stress testing. Remember this one. Since 2016, it was clear in the guidelines, and we are starting to do it. So any patient who has clinical features that suggest diastolic dysfunction and his ejection fraction is more than 50, and we fail to demonstrate diastolic dysfunction at rest condition, we go for diastolic stress test. And this is the diastolic stress test. Okay? Simply what you just do is you exercise the patient to the peak, during which you measure the mitral inflow and the E prime. And basically your target is the E prime ratio. So if it remains the same, improves or gets worse, meaning it increases. So if it increases, that means I demonstrated elevated LVEDP during exercise, which was not present during rest. And here, meaning I have demonstrated a low diastolic reserve and the diastolic stress test is positive. Okay? So the diastolic stress test is now one of the things we are starting to do for patients. Okay? People, by the way, are still not so into this test, they feel it's distasteful and is not so much promising. But according to the guidelines, it's there. It's there in the guidelines. Okay, I have done a couple of cases, and the yield is not bad at all. Okay, but remember this diastolic stress testing. Now choose the right answer here. You have this CT. Are you going to send for precardial stripping based on this CT? Are you going to strip from right to left? Do echo. If asymptomatic follow-up, AP X-ray is better than lateral. Fluoroscopy is better than X-ray. Steroid should always be tried first. Not necessarily one answer, by the way. So what do you think about sending for precardial stripping right away based on this CT? Wrong or right?
No.
Are you going to strip usually in the surgery when they do stripping? Are they stripping from right, left, or left, right?
Usually it's more in the right.
لكن عموما هم إذا كان uniformly distributed calcification and precardial thickening, the surgeon when he start stripping will start it right left ولا left right؟ يعني هيبدأ من RV لل LV ولا العكس؟
left right.
Why? You are right. عارف ليه؟ لأنه theoretically لكن السيرجن are so much يعني convinced إنه that's it. Probably they have studies for that. When you strip from the right side first, you release the RV. And when you release the RV, you increase the flow into the RV. And when you increase the flow in the RV, you increase the flow into
pulmonary, into the lungs.
Pulmonary and to the lung. And where?
Pulmonary edema.
Exactly. Why pulmonary edema? Because the left atrium is still imprisoned. The LV is still imprisoned. So that flow is supposed to go into the left side, but the left side is not yet accustomed to that flow. So the pressure goes high and patient might go into flash pulmonary edema. That's why they start left, they release the LV first, and then the right side. Okay? Okay, are you going to do echo for this patient?
Yes.
Yes, exactly. Yes. If asymptomatic, you are going to follow up. If asymptomatic, you are going to follow up. Mm-hmm.
Yes.
What I mean here is, if you stumble into this precardial calcification in chest X-ray or cardiac CT or whatever, and the patient is entirely asymptomatic, are you going to stop there and follow up, or are you going to do something?
Follow up, yes, you
of
can
course.
do
follow up without doing echo?
No, it's echo, yeah.
Exactly. So in asymptomatic patient, if I see precardial calcification, I should do echo. Then if the echo showed constriction, I might start management right from here. Not necessarily I wait until the patient gets ascites, edema, and all of that, right? So if I demonstrated a constriction physiology in echo, I will operate. Good. So the echo is important. Now, AP X-ray is better than lateral. You think that's right?
No. I think lateral is better. Lateral is better.
So lateral is better in the depiction of calcium. Fluoro is better than X-ray. Think it's right or wrong? Fluoroscopy.
X-ray, I think better.
X-ray is better.
Really? Fluoro is better. Fluoro is better. يعني الآن بس ببساطة جدا شوف الماك. How much and how clear you see the MAC in fluoro and you don't see it in chest X-ray. Okay, so calcification is also picked better in fluoro than in X-ray. AP or lateral. Now, steroid should always be tried first. No, that depends on what kind of constriction you are dealing with. Good. Now, what I see here? What is this? The one on the left, the one on the right. They are so different.
Yes.
What do you see?
IVC?
No, this is not the IVC. This is the M mode of the septum, interventricular septum.
Septal bound?
Yes.
A
restricted.
septal bounce. Exactly.
Bounce septal.
Septal
Yes.
bounce. Where is the septal bounce? On the left or on the right?
السبتال bounce في الليفت بجاي.
The right.
On the right. On the left. On the right. Okay. Here, see.
خليتني.
And I wish, yeah, there are actually, when it comes to the septal dynamics in constriction, and I wish not to take my words for granted, but go and look for it. There are two types of dynamics. One is called septal shutter. The other is called septal bounce, and they are different. The shutter is this kind of, the one you see on the left side. It's like, you see, the septum is lumpy and pumpy, okay? So, and the septal bounce is the swings, is respirophasic swings, respirophasic. But the shutter is not respirophasic. Both are sign of constriction. Sometimes we use them interchangeably, synonymously. We think this is this and who cares? But they are different, by the way. Dynamics are different. So when we talk about septal bounce, we precisely talk about the one on the right, not the one on the left.
Yes.
Though the one on the left is also a sign of constriction, it's not a bounce, it's a shutter. Now look at the septum on the right side. It shows both. It shows shutter and bounce. Don't you agree? So there is vibratory wave in the septum and there is swings, respirophasic swings in the septum. So it shows both the shutter and the bounce. Okay? So these are the septal manifestation of constriction. Now, this signal here, even though you get it so nicely and so clear like this, you should enlist anatomical data. Do you agree or disagree? بمعنى, if in echo I have seen this signal, this is coarctation, right? It's coarctation. You agree?
Yes.
Yes.
Type. Is that enough to diagnose coarctation severity and I have to stop here, or I have to go for CT, MRI, and or coronary angio?
Yes, madam. في diastolic reversal ده معناته في collaterals. وإذا في collaterals معناته عندي severe coarctation.
So I don't have to go for CT?
No, we have to go for CT.
CT because association.
You have to go like
anatomy.
أيوة. لكن ما عشان anatomical data، ما عشان to assess severity قصدي.
Exactly. So to assess what?
السايت والليجن ضيق حقه قدر شنو هنا، يعني بقدر اعمل ستنت ولا اعمل surgery.
Exactly.
For
That
anatomical
is so
data.
important. Yes, exactly. So these are hemodynamic data. The hemodynamic data will tell you about, I have coarctation. And probably it's severe coarctation because of the diastolic velocity is high and the peak is high and all of that. But that's not enough for intervention and or surgery, okay? Surgery, they need anatomical data. How much of a segment is involved and how much of collaterals are there and all of that, okay? So they need anatomical data. So always, when you have this one, you have to request for additional anatomical data. Why not echo? Echo is not good at all to see the anatomy of the descending aorta. The Achilles heel of echo is the descending aorta. We don't see it well. It's kind of blind spot. So it's not reliable anatomically by echo to see what's going on there. So you better see CT, MRI, or something like that, okay? Before you embark on any intervention. Now, grading of the mitral valve. First of all, mitral stenosis. Look at this tracing. You agree it's done wrong or right, or that is appropriate?
Right, done right.
Right. Yes.
Right.
Absolutely. Right. Topic.
It's done right, huh?
Yes.
Do you see that flare? The flare or the fuzz?
Yes.
Kind of hairy dimension. That one you should skip it. You don't have to include that one in your signal. You follow the modal velocity. And by modal velocity, meaning the dense part of the spectrum. Don't go to the flare, the smoke. If you go in there, that's erroneous. You get higher gradient erroneously. This is one thing. The other thing is that how much information you get by the gradient. In other words, how confident are you to diagnose severity of MS depending on the gradients?
The gradients is the
an area
gradient
is quicker
depends
than the
on
gradient. Diastolic dysfunction حاجة كده.
the gradient depends on other parameters like the heart rate, the blood pressure.
Exactly. Yes.
Diastolic dysfunction.
Yes. Exactly. Yeah. That's why the gradient in the mitral stenosis is downgraded a little bit. You probably have read that in the guidelines, at least between the lines. They are more into area than gradient because they know that the gradient is so load dependent, depends so much on the heart rate and the loading condition. So you might have patient with severe MS and normal gradient, and patient with mild, moderate, and it's more than 10. So the gradient is not enough. You have to see the anatomy of the mitral valve and the area. What is this?
Yes, right.
It's a true picture, not surrealistic. So what tumor is this?
Myxoma.
No.
Oh.
Not myxoma.
Fibroadenoma.
Fibro?
Fibrelastoma.
Fibroelastoma.
Fibroelastoma. And you have to know that because it's the most common tumor after myxoma. The most common benign tumor after myxoma is fibroelastoma. Sometime in the exam, they ask a sneaky question. They ask, the most common valvular tumor in the heart is? The answer is fibroelastoma. Valvular tumor is fibroelastoma. Tumor in general, benign tumor, fibroelastoma falls second. Myxoma first. Okay? So fibroelastoma is not uncommon at all. Probably you have seen one or two. So one is important, or what is specific about this tumor is that it has a stalk and shimmering edges, kind of hairy sort of mass. And you can demonstrate that shimmering edges in echo. So clear. And it's usually on the aortic side. So it's on the downstream of the valve, unlike vegetation on the LVOT side. This is on the aortic side. And one peculiar feature about this tumor is when you impregnate it in normal saline, it fans out like the one on the right. That's why they call it sea anemone, شقائق النعمان. You see the شقائق النعمان? Okay, it looks like شقائق النعمان في البحر. Sea anemone, it fans out. It's a magical tumor, by the way. Now, when are we going to decide about excision of this tumor? If it's large, more than 1 centimeter, and if it's associated with a stroke or ischemia. Why ischemia? Because sometimes, like the one shown here, it sneaks into the coronary ostium. it gets incarcerated into maybe left main and stuff like that, leads to severe stenosis and this kind of problems. Okay, so though it's benign, but can be malignant in presentation. Now, what is this? What is this? A guess. Something on the right atrium. They dissected the right atrium and that's what they get. It is, you see it a lot in echo, a lot.
خيارات بالله يا دكتور حاتم.
أديك خيارات. But I think somebody has said it already. Sorry?
KhairAllah network.
KhairAllah network, exactly. That is the KhairAllah network. But in echo, we don't see in echo, we don't see it as good as this one, but we see some, you know, filamentous structure is swimming into the cavity of the right atrium. Okay, so that is how it looks like. This is an embryonic structure. It is benign, no problem with that, but we usually have to report it. And sometimes can be naughty for the electrophysiologist, by the way. It happens once or twice. The electrophysiologists love the right side because they go there, they go to the right, the coronary sinus and stuff like that. So they put catheters there and the catheter get entangled. So it's jailed into this mesh work. So they cannot push it back, okay? So when you report it and they know, they might take some precautions and a special way of maneuvering, but when you don't, they might get imprisoned by this mesh work. So it can be naughty sometime if you have to go by catheter into the right atrium. Now these are thrombi. Of course, this is the LV thrombus, and the one on the right, it's a small deep thrombus. This is a thrombus in transit. When you have a PF4 or ASD, the thrombus can go through that one. You see the thrombus in transit and paradoxical thrombus and all of that. Of course, you know this one. Now, these are vegetation in gross anatomy, how nasty they look like and how virulent they can eat the valve out, leading to different form of damage. Okay. And here is the abscess formation I have been talking about. This is an abscess formation, and sometimes you have even fistulation. So it forms a fistula between the aortic root and the right atrium, the left atrium. So you can have a fistula as well with the abscess. And what did this here is an LA appendage thrombus. And we all know that the LA appendage is a nidus for thrombus formation. The question is, I want you to pick the right answer. The LA appendage is a functionless structure. Agree or disagree?
Yes.
We don't know?
Yes, agree.
Is a vital structure.
No.
Oh. Vestigial structure. Seemingly important structure or seemingly redundant structure. Now, the answer to this question is a bit tricky. Leave it for a while. Now, the LA appendage is the shelter of LA clot, more in AF with non-rheumatic mitral valve or more in AF with rheumatic valve. Now, I want the right answer here.
More in AF
with
rheumatic
بمعنى
valve.
آخر بمعنى آخر if you have an AF and I have LA appendage clot, this LA appendage clot forms in non-valvular atrial fibrillation. I mean, sorry, not the LA appendage, left atrial thrombi. In atrial fibrillation, which is non-valvular, it forms in the LA appendage by how much percentage? And compare that percentage to the thrombosis thrombi that forms in the LA appendage in context of mitral stenosis?
I think it's more common in non-rheumatic.
أيوة تمام. يبقى the thrombus is more likely to form in the LA appendage than the LA cavity in non-valvular atrial fibrillation. You agree? Yes, that's right.
Yes.
I give you percentage. 90 to 98% of the thrombi that forms in the LA appendage in non-valvular AF. Okay? Versus 60% of the mitral stenosis thrombi forms in the LA appendage. Meaning what? There is a 40% chance for LA thrombus to form in the LA cavity in MS. You see that? Okay? This is so important and has implication in therapy, because now you see, when we talk about LA appendage occluder and Watchman device and all of that, MS is out, because if you exclude the appendage, you still have 40% chance for the clot to form in the cavity. But now if you are dealing with non-valvular AF and you occlude the LA appendage, you eliminated the 98% chance of LA thrombus formation. So that's great. Okay? So that's important. Now, other thing I want you to see. This is the LA appendage in a patient with mitral regurgitation. See how resilient, how big, and how dilated it is. And that means what? The LA appendage modulates the LA pressure. So if you have high LA pressure for whatever reason is, the LA cavity dilates, but sometimes the LA appendage dilates even more. It's more resilient than the LA cavity. And that will vent the pressure, will modulate the pressure. So if you eliminate the LA appendage by occluder or cutting or ligation, you have extracted probably an essential venting, pressure venting structure. That might be not good on the long term. عشان كده في studies الآن still in the pipeline about patients who have undergone Watchman device, and they see how the pressure behaves. Lakin theoretically, if you eliminate this structure, you might end up having higher LA pressure, وده ممكن يكون detrimental in terms of symptoms and clinical outcome. Okay? الحاجة المهمة جدا and I want you to know is this one. The velocities. أي واحد فيكم ربما إذا اشتغلوا في التي by the way التي ما تنزعجوا له، طبعا عندنا محاضرة هتكون dedicated للتي قريبا إن شاء الله. This is the velocity of the LA appendage. When we interrogate the LA appendage by PW, that's what we get. عندنا تقريبا four velocities. 1, 2, 3, and 4. Look at the first one, which is here. This one. This one. This is the atrial kick velocity, meaning what? During atrial contraction, the LA appendage contracts. And that's the velocity. Now, look at this one here. This is what? This is the early diastolic velocity. So this is when the mitral valve opens initially, the blood flows out of the LA appendage as well. So this is the flow, initial flow. Now, these waves, you don't have to care about. These are systolic waves that happens in the LA appendage. The most important two are this one and this one. Okay? Now, look at this one here. I want you to focus on this. Look here. So, and this is so important because it tells you why things are what they are. This one here, this velocity is what? The atrial contraction velocity. Where is the atrial contraction velocity here? This one. In the mitral inflow, The atrial contraction velocity is this one. The flow is this one. You agree? This is the flow.
Yes.
Are you following?
Yes.
Now, in the LA appendage, the atrial contraction flow is this one. Which one is big? It's big in the LA appendage or big in the mitral inflow?
LA appendage.
Exactly. What
than
does that
70.
tell you? What
More
does
than
that tell you? Exactly. What does that tell you? In the
there is
LA
no
appendage.
obstruction, no thrombus.
أيوة, لكن what does it tell you in terms of flow? Meaning the LA appendage is more dependent
Contribute
on
more
the
to
LA
atrial
contraction, than the mitral inflow. The mitral inflow is more dependent on the initial flow than the atrial contraction. The LA appendage is more dependent on the atrial contraction than the initial flow. You agree?
Yes.
What does that tell us? Now, when we have atrial fibrillation, what do we have? We will lose the atrial kick. And when we lose the atrial kick, the mitral inflow will survive because it's not so dependent on the atrial kick. But the LA appendage will not survive. The flow is basically
More
dependent on the
stagnation.
atrial contraction. Exactly. That's why in AF, thrombi forms in the LA appendage and not in the LA cavity because of that reason. Okay?
Yeah.
Losing atrial contraction and the sequence of that. Good. Okay,
Normal
so
more than 70.
more than 50 is considered okay. Okay. Right. Now go here. What is this? This is the surface of the heart, and we have some black spots.
Angiosarcoma.
Another guess?
Melanoma.
Yes. Thank you so much. Melanoma. And what is peculiar about melanoma is that it has a special predilection to the heart. Okay? So the chance, if you have a melanoma, to have a cardiac metastasis is the highest in all tumors. Okay? طبعا في حذر هنا لما يقول لك the most common cardiac mets are from which cancer? It's from the CA breast and CA bronchus because they are more common. لكن الميلانوما is the most common tumor to metastasize to the heart. You agree on this?
Yes.
Okay? Yes. So this is important. Okay. Now, what do we see here? What is this?
This
For
is
those who...
Diastolic flow reversal.
No, this is عشان اسهلها لك. This
pulmonary
is a
pulmonary venous Doppler. Pulmonary venous Doppler.
Pulmonary arterial Doppler. This
Yes.
is pulmonary artery.
Yes, it indicates severe pulmonary hypertension because.
Thank you so much. Thank you so much. So this is important. You remember when we say that when we lose the tricuspid velocity for the calculation of pulmonary artery systolic pressure because of weak signal, because of severe TR or whatever, there are so many other measures we can still fall back on. One of which is this pulmonary arterial Doppler. Now, normally it looks like this. Now, when you start to have pulmonary hypertension, it looks like this. When it becomes severe, it looks like this. So what is the difference between these? Compare this one to this one. You see, this one is called the acceleration time, which is the time from the onset to the peak, this one, this time. This time is short. Now, compare it to the normal time, it's long. And that's why we can calculate the acceleration time of this signal. And if it's lesser than 100, we are dealing with significant pulmonary hypertension. The other thing, if I demonstrate a mid-systolic notch, in this signal, again, I'm dealing with severe pulmonary hypertension. Okay? So the pulmonary arterial Doppler is also useful in the assessment or analysis of pulmonary hypertension. Good? Okay.
Dr. Hatim on RVOT.
This is the
This,
RVOT, exactly. Yes,
pulse.
yes, from the RVOT. Yes. Okay.
Dr. Hatim, معلش, which is the best view to elicit this sign?
This is the short axis, from the short axis. When the aorta in the middle, you have the pulmonary artery on the right side, tricuspid on the left side. And you drop your interrogation line, yes.
Okay. Thank you.
I need a better, intelligent guess. This is really tough. I used to show it to our fellows, and most of the time nobody is getting it right because seemingly it's more of, it needs sort of visual hallucination. So what do you think about this one? First of all, tell me, is this patient having any prosthetic valve or no?
Yes.
Yes, there is prosthetic.
Yes.
Exactly.
Yeah.
Exactly. So I have prosthetic valve. I have precisely metallic valve because it imposes these metallic flaps you see in the opening and closing end. So what else?
I think there is gradient over the mitral
Very
valve.
good. This is aorta, by the way. Okay. So I have gradient.
Aortic valve.
Yes, and this gradient is it's kind of 60. So the peak gradient is 60. So that means I have high gradient across a metallic aortic valve.
Yeah.
Now look at this one here. This flap, metallic flap, or the metallic imprint, during the opening, how does it open? And how does it closes? You see two lines, right?
Yes.
Yes.
When they closes,
one line.
when they close it, they close with one line, but they open with two lines.
Yeah.
They are supposed to open and close with one line because I have two discs, like they are synchronous. So they open together and I have one flap, and they close it together and I have one flap. So I am supposed to have a single metallic flap in the opening and on the closing. Now I have two during the opening time. And that means I have desynchronous opening, meaning في واحد stuck.
Stuck valve.
Okay? So it's stuck valve, exactly. So if you see this one, the duplication of the metallic flap in the closure or opening, it may indicate a stuck valve. طبعا, along with the gradient, I already have high gradient. So this is an additional feature, of course. Okay? So remember this one. Good?
Yes.
I will skip this one and this one and the IVC type. What do I have here? This is color M mode.
Color M mode.
Exactly. Color M mode of the descending aorta for two patients with AR of different degree. The one on the right and the one on the one on the top and the one on the bottom. Which one has more severe AR?
Down.
The lower
Why?
one. Down.
Why?
Hollow diastolic.
Exactly. Very good.
Hollow diastolic.
Very, very good. Yes, that is it. You see here the diastolic reversal. This is the diastolic reversal. Compare it to this one. It's just early diastolic reversal in the one on the top, and it is hollow diastolic, the one on the bottom. Meaning it's more severe. The other thing, look at this one here. This is what? This is the systolic flow. Look at the systolic flow. Does the systolic flow changes in severe AR? Does it change?
Yes.
Yes.
How? How it changes?
The peak gradient is higher. Or
exactly.
the peak velocity is higher in the bottom, the signal in the bottom.
It may give like CVS. It's going to large volume of blood.
Very good. Thank you so much. AR, when severe enough, it gives functional aortic stenosis because the flow going out of the aortic valve is higher than the capacity of that orifice, even if it's normal. That's why I get flow acceleration and I get functional stenosis. And when I put the stethoscope, I might get a murmur of aortic stenosis as well. And I have no aortic stenosis. I just have AR. So this is the flow acceleration. This is the systolic flow acceleration in severe AR without AS. It's just because of severe AR. Okay. Right. I will skip this one and this one, and because I know now. Now this is the medial and lateral, the one I have showed, the annulus inversus. The lateral E prime is slower than the medial E prime in constriction. So see the E velocity of the medial is much higher than on the lateral. And this is a sign of constriction, like we said. This is again the L lump or the L hump of the mid-diastolic flow. Recovery, I will not take it. I will just take the last one, which is this one, probably, or the one other. What do you think here? What is this? What is this? Aortic, pulses, exactly. You remember we started our presentation with electrical alternance, and now this is pulsus alternance. It's a sign of what?
Severe LV systolic dysfunction.
Very good.
Yes.
Now I need an intelligent guess for this. Again, it just looks like pulsus alternance. Beat to beat variation in the amplitude, but it is not pulsus alternance.
EVCs.
Take it from
by
there.
Gemini.
This is
by Gemini.
Not by
dissociation.
Gemini. AV dissociation. Why?
ممكن تكون SGP sometimes لما تكون ماشية من
dissociation.
This is pacemaker. This is the pace rhythm.
pacemaker, أيوه.
So
It's
it
spikes.
seems.
Exactly.
في
This is
spike
the
ومرات بيكون في بي ويف تنسينال بي ويف مرات بيكون تنسينال بي ويف ومرات لا يعني شكل المود بتاع VDD.
Yes, exactly. So look at the pacemaker on the ECG tracing. See, for example, this one. See which one? Let me take this one. Sorry. This one. What do you see? I have A and paced ventricle. Now look at this one here, the second. I don't have A and I have paced ventricle. What do I have here? I have A and paced ventricle. No A and paced ventricle. A and paced ventricle. No A and paced ventricle. And so on and so forth. So when you have A and paced ventricle, that's what you get. When you have no A, just paced ventricle, that's what you get. So this looking like pulsus alternance, but it's not. It's the effect of a pacemaker with intermittent appearance and disappearance of the A wave. So when we have A wave, we have more of amplitude. When we don't have A wave, we have less of amplitude. And that is commonsensically because we know that the atrial contribution is like 30%. So when we lose 30%, we get lesser height. That's what we get. So though it looks like pulsus alternance, but it's the influence of the pacemaker. Okay. Good. And now, what is this?
I consider as AV dissociation?
Not really, because this is a pacemaker actually, and it's pacing the ventricle only, and it's pacing the ventricle nicely. The only problem we have is that sometimes we have A wave, I mean P wave, and sometimes we don't. Okay? It's not pacing that, it's not pacing the atrium, single chamber. Okay. Now this is the CT, and the CT is so important. We're going to have a dedicated presentation on CT. But what I want you to know now is that the CT is so good in having negative predictive value in ruling out. It's not as good in ruling in, but it's great in ruling out coronary artery disease. It shows the artery in different formats, one of which is called multiplanar reconstruction, the one on the right. which is great. You can study and analyze the vessel in across its entirety for any atheroma like this one here. So you can see I have mixed plaque, calcified and non-calcified plaque. And if you do coronary angio for this patient, you might not appreciate any significant stenosis. But in cardiac CT, it can pick up the stenosis. I mean, it can pick up the plaque at early stage when it's still not stenotic, when it's still not encroaching upon the lumen, it's still on the wall. Remember, the coronary angio of cath does not see the wall, it sees the lumen. CT sees the wall and sees the lumen. That's why when you have a large amount of soft plaque occupying the wall, you miss it in coronary angio, but you will not miss it in CT. That's why CT has a higher negative predictive value for ruling out than coronary angio. Okay. And this is the AP and lateral chest X-ray for the calcification, showing calcification better in the lateral. And now this is what? Another important utility of cardiac CT is when you are suspecting anomalous venous origin. Anomalous origin. Sorry, anomalous coronary origin, exactly. Like this one here, this is the RCA arising from the left, okay? Then its course, how it courses between the pulmonary and the aorta, and we call that a malignant course. So we know exactly not only the anomaly and the origin, but how it courses. And most importantly, we also know about this part. This is also important. اللي هو the origin and the angulation, how much the artery is angulated from its origin, because that has a lot to do with the clinical presentation of this anomaly. It's not the course, by the way. The origin is more important than the course. So if the origin is angulated and slit-like, it's more likely the patient to be symptomatic and deserving of treatment than if not, okay? In coronary angio, you might see the anomalous coronaries, but not as good and not as informative as in cardiac CT. So cardiac CT is the best modality for anomalous coronaries, okay? And now, what is this here? This is a SPECT for a patient. What do you see? Any abnormality?
Is FDG or NBI?
This is SPECT, yeah, MPI. MPI. What do you see? Anything abnormal? I know you are accustomed to seeing the different color codes. This is grayscale, which is
LV dilatation.
not so good as the bright colors we have.
What is the rest and what is stress?
LV dilatation.
Very good. This is one important thing, which is, you know, the data set in MPI is put like stress, rest, stress, rest, stress, rest. So usually the stress data on the top. The first two rows are the short axis. The one in the middle are horizontal long axis. The one on the bottom are vertical long axis. So short axis, horizontal long axis, and vertical long axis. By this depiction, I see all the segments of the heart, the 17 segments of the heart, okay? Now, the stress and rest, compare the stress and rest, and you said I have a transient ischemic dilatation or stress-induced dilatation. Yes, because you see the cavity is larger in stress than in rest. That indicates what?
Cerebral disease.
Multi-vessel disease. Yes.
أو left main.
Three vessel disease and left main. لأنه معناته شنو؟ معناته it indicates a global LV endocardial ischemia induced by stress. معناته I have very significant ischemia. Okay. Even if I have no perfusion defects, If I demonstrate a TID, that is significant in the absence of perfusion defects. طبعا in this patient there are perfusion defects. You look at the septum يعني if you compare this one here with this one here, the septum is clearly okay, or anterior wall to some extent and all of that. ولكن the TID is so pronounced here, and this is significant. So this is a strongly positive. Patient should go for coronary angio, of course. And thank you so much. Thanks a lot. So just يعني أنا بس أحب أعرفكم بأنه this session was supposed to be run by Dr. Jamil. Unfortunately his nephew passed away today. فاتصل واعتذر وبيعتذر منكم جدا. وأنا in short notice عملت ال preparation ده وأتمنى إنه يكون كان satisfactory to some extent. If you wish to ask any questions about anything, you are welcome.
Thank you so much, Dr. Hatim. Very interesting session.
You are so most welcome. So most welcome.
شكرا كثير.
ممتاز والله، تسلم، جزاك الله خير دكتور حاتم.
شكرا لك.
تسلموا ان شاء الله، وان شاء الله دائما نكون معاكم.
نكون بنفس الطريقه اذا الشباب وافقوا، يعني مغطي كل او جزء كبير من الكارديولوجي.
انت عارف انا حقيقه بكلم الشباب دائما،
يعني كميه من السورسز يعني بتاعت العسكري هذيك يعني بالعربي كده.
هي تعرف انا في رايي انه اتس نايس انه الناس تتكلم بطريقه زي دي، يعني بانوراميك يعني وانتراكتيف سيشنز واشياء زي دي rather than tough topics to be يعني مثلا diastolic dysfunction, aortic stenosis. I don't like it. لكن طبعا ما قادر ألزم المشاركين معانا بشكل معين. Usually they love to present one topic at a time, which is okay. لكن أنا عموما معاكم حكون more of يعني exam oriented, more of يعني النوع ده من الانتراكتيف سيشنز. ممكن نعمل interactive sessions كثيرة عن data presentation, data interpretation كاملة، ECGs وأشياء زي دي، وclinical cases، MCQs. حتى أنا خدت عندي كم sessions حيكونوا MCQs basically. فحنشتغل في المجال ده يعني. لكن كمان الناس التانيين قد ياخدوا topics عادية ويقدموها لكم بشكل عادي. عموما نحن متفقين الآن إنه في تغطية كاملة أسبوعية إلى ديسمبر معاكم، حيكونوا في ناس موجودين بيقدموا لكم يوم السبت. إذا أنتم عندكم أشياء معينة حابينها، أنا أتمنى تتواصلوا معي على الخاص، لأنه أنا في يدي تغيير حاجات كثيرة جدا فيما يخص بالذات الكارديولوجيست اللي في السعودية هنا، وممكن أديهم توبكس معينة يقدموها لكم اللي أنتم عايزينها. نحن ما عايزين نفرض عليكم البروجرام ده إحساسنا به، لكن إذا أنتم عندكم deficiencies معينة just let me know.
دكتور حاتم، انا اظن انه البروجرام اللي اتخذته كان جميل جدا. نحن عندنا ديفيشنسي في بعض الطبق حنرسلها ليه، لكن ما دارينها تكون with change of البروجرام. يعني احنا دارينا add on البروجرام. فما اعرف لو انت يعني زمنك بيسمح او بتاع تكون كيف.
ابدا ما في مشكله يا عبد الله. زي ما انا كان قلت لكم قبل كده انه انتوا الان نحن بنتكلم عن سبت صح؟ أيوة. لكن اذا السبت ده خلوه untouched، السكيدول النزل حيواصل كما هو. حبيتوا additional topics ثانيه عايزين ايام اضافيه على يوم السبت وانتوا جاهزين لها just let me know about it. اوكي
احنا هنحدد التوبكس وبنتواصل معاك ان شاء الله.
تمام جدا جدا. اوكي فما فيها مشكله. واذكركم انه انا في التي اي حيتقدم قريب، لانه شايف عدد كبير من الناس كانوا عايزين التي وكده. حنقدم التي في سي تي، في ام ار اي، في نيوكليير، حاجات الدياجنوستكس دي كلها حتتقدم، ما حيكون فيها مشكله. تمام، بناس كويسين خالص متخصصين في حاجاتهم دي. فدون وري، اي اديشنال حاجه فوق السكيدول اللي انتوا عندكم let me know about it وانا هعمل arrangement ليها.
أصلا دكتور طارق يا دكتور حاتم، طارق الحسين
لازم ادخلهم لازم
ايوه
ندخله
لازم
طارق.
والله، خاصه في
طارق
في الإي سي جي
لازم
والانتراكارديك
ادخله.
تريسنج.
طارق هو مش انت، طارق يعني is all round يعني
ايوه،
يعني
وبعدين الحاجات دي عنده
cardiology
أمراض
great يعني.
جاهزه، يعني ما تحتاج يعني عنده a lot of.
yes of course اكيد. يعني انا شفت هسه مجموعه من الناس لسه ما وصلتهم، لكن طارق one of my main targets طبعا، لانه he's a great educationalist وهكذا. فحيكون معانا ان شاء الله. don't worry.
ان شاء الله. خاصه موضوع الاي سي جي يعني عنده a lot of حتى الانتراكارديك تريسنج.
لا شفت انا الاي سي جي بالمناسبه جايب لكم واحد بس انتوا ادوني فرصه معاه. كلمته اوريدي وهو موافق مبدئيا. عنده ورك شوب كامله بتاعت اي سي جي اللي هو دكتور اسمه منو هو؟
امير صديق،
احمد الفقيه.
احمد الفقيه، لا خلاص هذا الطب.
فكلمت احمد وهو
ايوه انا
استبشر
عندي يا
جدا
دكتور
جدا.
حاتم برضو عندي الاسئله الاي سي جي بتاعته برضو في فايل كبير يعني.
ايوه بالضبط.
طبعا
طبعا
عبد الله يرسلها للشباب.
امير عنده برزنتيشن وبرضه وي بوكت هيم فور برزنتيشن، يمكن حيكون عن البيس ميكر ولا انتركارديك تريسنج. انا منسق مع الفقيه لو لقينا يوم معين كده غير ايام السبت ندخله
ممتاز. وبرضه لو
في يوم.
لقينا برضه حالي الشهري عن الام بي اي.
ايوه لا ما عندك اي مشكله. شفت هم عندنا نحن مجموعه كبيره جدا حتى من السعوديين والنون السعوديين اللي هم ريدي. الموضوع
أيوة.
مع الفيرشوال ده بيسهل علينا اللقاءات ثاني. طبعا ما حيكون مشكله. فكل الحاجات ده انا في بالي وكلها حنظبطها ان شاء الله. ما حيكون عندكم مشكله باذن الله.
ان شاء الله. شكرا جزيلا.
تمام. تسلموا يعطيكم العافيه ونلتقيكم قريبا ان شاء الله. يلا في امان الله.
شكرا لك كثير دكتور حاتم.
تسلموا يعطيكم الف عافيه ان شاء الله.